So for this case, this is a patient that is morbidly obese, has a horrible leg abscesses on both legs, developed a deep vein thrombosis, which ended up creating a pulmonary embolism. Patient is also septic and is currently in acute kidney injury. Initial event settings was APRV, a P high of 20 centimeters of H2O, a T high of 5.00 seconds, an FiO2 of 0.30, and an SpO2 of 94%. So with the setting of P high equaling 20, we see that there's significant lack of distribution to the dorsal and mid-dorsal region. The ventilation seems to be centered around the mid-ventral as well as the ventral region. Therefore, this could cause atelectotrauma, increased strain on the alveoli adjacent to the collapsed ones in the dorsal region, as well as the reduced surface area of alveoli would increase the amount of stress in the ventral and mid-ventral regions. Without the electrical impedance tomography to get this regional distribution of ventilation, we probably would have never known that the patient had any of this collapse in the dorsal region. The patient was on an FiO2 of 30, the P high of 20 offered a superior mean pressure. There was a long inspiratory time, so the T high was 5 seconds. So we were actually quite surprised when we put the electrical impedance tomography and realized that there was such poor distribution of ventilation. So these kinds of situations, we can refer to this as subclinical atelectotrauma. So under electrical impedance tomography, I guided the incremental PEEP titration of the P high by 2 from 20 right up to 30. Around a P high of 24, I started to see some improvements in the dorsal distribution of ventilation. We can see that where the blue is appearing where it previously did not. And when I finally got to a P high of 30, I had a very significant increase in dorsal distribution of ventilation. After the P high titration, what I was able to do was go to the custom analysis to look at where we were winning regional compliance or losing regional compliance. I also then did another version of a P high trial, and in this one it will let us know if there's any overdistension or atelectasis. So here's the result of the customized analysis. We can see that by the time we hit a P high of 30, the lung had become 73% more compliant as compared to a P high of 20. So the optimal P high for this specific patient that is helping to recruit the dorsal distribution of ventilation is a P high of 30. This one here is a P high trial where orange, if it appears as orange, that would be compliance loss on the higher P highs, and gray is a compliance loss on the lower P highs. So we see on the first squares on the left, the first two, that is a P high of 20 and 22. We see that gray region increase. We see the gray region that has a significant percentage of compliance loss, and it's gray, indicating that the lung is not being overdistended, but is underinflated and at risk of atelectasis. We see that this is corrected as we reach 28 and 30. Here we're looking at the end inspiratory lung impedance or end expiratory lung volume. We see the difference between the initial P high, that's the center square, that was 20, and then after we see the significant improvement with the square on the top right of your screen, which is the P high of 30. If you go completely to the left side of the screen, the blue here indicates where the increase in lung volume at the end of inspiration is occurring. Below those squares, you'll also see these white lung impedances that are in an upward trajectory, meaning a recruitment of the functional residual capacity. With the electrical impedance tomography, we're also able to measure the changes in the functional residual capacity. On the right of your screen, you see on the top 3.44. This is an impedance value. Volume equals impedance. Therefore, these positive impedance values lets us know that we're increasing the functional residual capacity. If you multiply each of these impedance values by the reference tidal volume, which is below at 501 mLs, you're able to translate these impedance values into actual milliliters. So the global increase in functional residual capacity when going from a p-high of 20 to a p-high of 30 was 1,723. When we multiply the 0.19, which is ventral, that's 95 cc's of increased aeration at the end of expiration. The mid-ventral is 1.27. We multiply that by 501, and we get an increase in the mid-ventral region of 636 milliliters. The mid-dorsal, multiply 1.63 times 501 also. We have an increase of 816 mLs. And finally, the dorsal region, multiplying the impedance value of 0.34 times the reference tidal volume of 501 on the bottom left in blue, we have an increase in functional residual capacity in the dorsal region of 170 mLs. When looking at the top left of your screen, you'll see all of that blue saturation in that blue box on the top. Blue means an increase in volume. If we were losing functional residual capacity anywhere, we would see this in orange, as well as they would correlate with negative impedance values. So blue is gain in distribution of volume, and orange is loss on this diagnostic panel. So traditionally, we think of APRV when there's severe hypoxemia. It's often thought to be used when there's for rescue, when the lung is already seriously damaged. But if you think of it, this patient here had a FiO2 of 30. Even though the FiO2 was 30, the oxygenation didn't seem a problem. When we installed the electrical impedance tomography, we saw that there was no distribution to the dorsal region, which over time can cause subclinical atelectatrauma. When an alveoli is derecruited, what actually happens is that it actually pulls on expiration the adjacent healthy alveoli. So overdistension can happen on expiration. So seeing that the patient has an FiO2 of 30, we know that the patient has good diffusion capacity through the alveoli. So why not use APRV and start stretching out the time high so that you're extending the CPAP level and you're creating a lot of diffusion, a lot of CO2 is accumulating in the alveoli without the chest moving while it's perfectly splinted open. During those releases, you're going to get a lot more concentrated CO2. So what you end up doing is you are able to decrease the respiratory rate and the minute ventilation, meaning the chest will move less, a lot less. Especially with this lady, we know that we managed to recruit some amount of the dorsal area, but it was far from perfect. So there's still that high risk of injury, high risk of stress, as well as the ventral areas, which are more compliant, the danger of overdistension from that area, because we didn't recruit the whole surface area. Therefore, we're increasing stress. Think of it like in the ICU, you have 20 patients and you got 20 nurses. Therefore, that's one patient per nurse. But if you're down to 5 nurses, now you still have 20 patients, but now each nurse has to take care of 4 patients, which increases the stress. The amount is still there, but there's less workers. Think of it the exact same way with the alveoli. So by using the diffusion capacity on patients with low FiO2s, you're able, and it's quite impressive, you just see some of them, they're diffusing gases so well that you end up getting rates of 6 and 8. That's wonderful, especially when the lung is not perfect. Therefore, by using the diffusion of the lung, you're able to move the chest a lot less, and you're able to protect it. All right, thanks guys. I'll show you the blood gases. So when the APRV was set up, the T-high was initially put at 2.5 and then increased to 3. If you look below, the pH is 7.43 and the CO2 clearance is 47. With the 2.5 T-high, we had a rate of 20, and then after the rate or the mandatory releases went to 17, patient was not breathing above. The patient was not under any heavy sedation. Patient was only on 100 micrograms of fentanyl infusion. If you look again above, there's some total rates of 22, 17, and right up to 30. This is when the patient was being stimulated. Patient was in a lot of pain due to that left-sided abscess and necrosis that had caused the PE. If you look, the T-high was then extended to 5 seconds, and again, an hour later extended to 6 seconds. You have a pH of 7.24 and a clearance of CO2 of 47, with a rate that's decreased to 10 now. Here we see on the top now that the average rate is around 9 to 8 releases, and still we have a very good blood gas, 7.45, and a CO2 clearance of 44. So again, this is why I am an advocate of using APRV, because the lung is an organ that uses diffusion. So why not use diffusion in patients with good diffusion capacity in the alveoli so that we can move that chest a lot less, especially when we know that the aeration, especially in the dorsal, even though we've recovered a certain amount, is not perfect. So I'll end this video just with a brief recording of the ventilator screen on APRV with a stretched out T-high of 6.